Can you see that all right?
I can.
Perfect. All right, go ahead and get started when you're ready.
Okay, so I have a 42-year-old white female. She reports receiving a Hep C diagnosis as a child. Age 14, she was never treated. Her parents were IV drug users, and she said she was stuck by a needle. She does have a history herself of substance abuse, opioids, cocaine, and benzos. She does smoke tobacco. She doesn't drink alcohol. She uses medical marijuana for a seizure disorder. She's currently in a methadone clinic for about 3 years now. She's been vaccinated for both Hep A and Hep B. With her labs, her CBC showing a low hemoglobin in her hematocrit. Her iron studies are a little low as well, and we're treating her with supplementation. Her renal function and liver function studies are pretty normal. She's HIV negative. Her viral load, 36.2 million, and her genotype is 2B. Her EPRI score, now on there it says 0.232, and her MELT score is 6. So my concerns or questions, would the treatment recommendation be for Mavorite for the 8 weeks or the Epclusa for 12 weeks? And with consideration of how long she's had hepatitis, since childhood, do you all recommend any further testing prior to me treating her?
Thank you so much. And I can bring this case back up if anybody needs me to. I just need to be able to see everybody. So does anybody have any clarifying questions they would like to ask? All right. And then we can go into the recommendations. Go ahead and unmute, or
I'll go ahead and unmute. This is Kaylee. Thanks so much, Keisha. This is your first one. Excited for you. This is a cool one too. I mean, my goodness, being diagnosed at 14 is just insane. So, but I mean, I would tell you that even though she's had this diagnosis since childhood, she doesn't have any evidence of fibrosis. So, she's genotype 2. So that's actually probably why we haven't seen any fibrosis yet, is that's the one that tends to be the least aggressive in terms of liver disease progression. So yeah, with her, you could do 8 weeks of Mavorite or 12 weeks of Epclusa. I would say that with her being on the famotidine, if you do choose to go with the Epclusa, she would either need to take that famotidine with the Epclusa or separate it by 12 hours. You may notice too, it says she has some neuropathy. I'm not sure if you have the underlying etiology established or not, but Hep C, it may be an extrahepatic manifestation, so she may actually report that improved some with treatment. I would say, generally speaking, in a patient that has a long natural history of having this infection, so almost 30 years, generally speaking, I would say, make sure to get an ultrasound. In this patient, she's an F0, she has no transaminitis, she doesn't really have any other risk factors for liver disease progression. So you could get a liver ultrasound. I really don't think it's going to change your management at all. I certainly wouldn't, if you do choose to get one, I wouldn't delay her treatment while you're waiting on that imaging study, because it's probably going to be fine. But if she did have transaminitis, or she was diabetic, or had, certain other risk factors for liver disease, then if you hadn't already got one, I would make sure to get that as well. And the only other comment I would make is just in terms of birth control, if she's on any contraception. Do you know?
Okay. She is not, and I did talk to her about that. I called her just to check in with her yesterday, and I asked her about birth control. She does not want birth control. She said she just will abstain.
Okay, and that's fine. Yeah, as long as I usually check a baseline pregnancy test anyway, and just make sure, or even I'll have them do a home one. If she's like, I just got off my period, you know, I'm sure I'm not, but just counsel that we don't have we have a little bit of data that these will probably be okay with pregnancy, but just not really enough support. So it's just recommended to avoid pregnancy until after treatment's completed.
Okay. Thank you. And I did get a liver ultrasound.
I saw that after, yeah, I saw that that was from July and it looked fine.
It was normal. Yes.
Yeah,
Mhm.
okay. Yeah, I hadn't seen that when I was looking through it earlier, but yeah, so she's somebody that I think you're perfectly fine to treat with either 8 weeks of Mavyret or 12 weeks of Clusa, whichever one you have a preference for, whichever she would prefer.
Thank you.
Thank you so much, Kaylee. Do you have any other questions, Keisha?
No, I don't. No.
All right, great. Thank you. Great job. Really appreciate it. Anytime. Turn in those cases. We love them. All right, Jennifer, we'll go ahead and move on to yours. Give me one moment. All right.
Elizabeth, you're breaking up a lot, I think, or maybe it's me.
Oh no. Can you hear me now?
Yeah. Gosh, I hope it's you and not me. Can you hear me okay?
Yeah, I can hear you.
Okay. She said that was a really interesting case. Somebody infected from childhood. Thanks for presenting. So, my patient, or this patient, is a 55-year-old African-American male who was referred in-house. He actually started in our MAT program and then dropped out to get Vivitrol from our psychiatrist, which he thinks is going to work better for him. He was recently released from jail. He was just diagnosed this year in our facility. He thinks he was tested in 2006 and was negative. He has a long history of IV and intranasal drug use, and he also had a blood transfusion in 2010. He denied male sex partners. He says he's been sober for 7 months without medication. Interestingly, when I got back a urine drug test on him, it did have fentanyl in it, so I need to talk to him about that and just check with him on his commitment to his sobriety. But he is now on Vivitrol and does not drink. He said he has in the past, but never had a problem with it. He's living with his mom as he gets reestablished in the community. He has depression and hypertension and does smoke. Those are his medications. Amlodipine, carvedilol, Claritin, and Lexapro, Remeron, as needed, Zofran, and now Vivitrol. He is not immune to hepatitis A. We've contacted him to start vaccines. He is immune to Hep B. His labs, his white count was slightly elevated the day I saw him, so I just plan to repeat that. It was 11.8. An interesting thing I failed to mention in his demographics is he's currently uninsured, so we're working with him on that. At any rate, if you can keep scrolling there, Elizabeth, I don't have this in front of me other than what you're showing us. His labs were pretty good other than that white count. His APRI was 0.17. Child Turco-Pugh class A, MELD score was 8. Iron studies were normal. His vitamin D was low, and I sent him a phone call saying I was going to send a prescription. Then I failed to send this prescription, but I will do that. He's HIV negative. Genotype is 1A, and his viral load is 254,000. He's FibroSure was an F0, and I don't have an ultrasound yet on him. That's scheduled. I didn't see any medication interactions there, but I always like to have people confirm that for me. I was thinking Maverick for 8 weeks with him. I will start him on the vitamin D and the Hep A, and then ultrasound is pending, and we're working on his insurance. So I think those are the only things with him.
Excellent as always. Thank you so much for that case, Jennifer. Does anybody have any questions about this patient? All right, if not, we can go ahead into the recommendations.
That's so weird.
All right, I guess I'll go, Jen. This is Kaylee. Just a comment I wanted to make before we go into the medication recommendations, but I always wonder if someone's told me they've been sober for 7 months, but all of a sudden now they want to get on MAT. What's really going on? Because that's a while of sobriety which is good. I'm glad that he's deciding to get on Vivitrol, but I always wonder that. And sometimes I feel like when I ask sobriety questions, when they say like 7 months, they mean from injection use. They don't necessarily, then they'll say, I call them out on there like, oh yeah, but I was still smoking fentanyl. So I wonder if maybe that's what he's doing. So I know you're planning to clarify that, but even just things like still counseling on overdose risk reduction, making sure he's got naloxone, fentanyl test strips, those kind of things, even if he is started on the Vivitrol. And then in terms of medication recommendations, now we always gravitate towards the Maverick for 8 weeks or Epclusa for 12 because those are what's covered under Medicaid, and either of those would be fine. But he's also somebody that would qualify for Harvoni times 8 weeks, and so we don't really talk about Harvoni as much anymore. It's not typically a preferred agent on some insurances now. But he's somebody, his viral load is less than 6 million. He doesn't have fibrosis. He's HIV negative. He's treatment naive. And so he's somebody in genotype 1. So he's somebody that you could treat with a shortened duration of Harvoni as another option. So as a third option, which is only 1 pill once a day. So it's a little less pills than Maverick, but the same duration. Yeah, so I think if he's trying to work on getting Medicaid, though, then the two that you mentioned are going to be the most appropriate because they'll be covered under Medicaid.
Yeah, I'll say something. Oh, am I still? I guess I'm unmuted too. Yeah. So, you look at this guy and he's 55, he smokes and he has hypertension. And where was I going with that? Oh, and his white count was high. So, he's, remember the white blood cell count. I've said this a few times on Echo is like the poor man's, cardiac CRP. So it's an overall marker of inflammation on occasion. And there's an absolute association between the chronic inflammatory state of hepatitis C and increased risk of cardiovascular disease. And I was trying to get a number for you. Dr. Feinberg had sent me a study recently that basically, it was just a big meta-analysis. I'm going to read to you because it's not from my brain. It's a meta-analysis that had a large sample size that showed that HCV infected people post-treatment. So this is if you get an SVR, a sustained virologic response to cure, you can reduce the adverse cardiovascular outcomes and mortality. So this guy, it says you can reduce all-cause cardiovascular disease, MIs, cardiomyopathy, peripheral arterial disease, blah, blah, blah. So only thing that made me think that this guy might be increased risk is, again, his age, his hypertension history, and that increased white blood cell count. So extra motivation to treat, not that we any longer, sort of select patients to treat based on comorbidities. We try to treat everybody, but extra motivation to get them treated. And yeah, that's it.
Thank you both. My internet connection is unstable and I caught most of what both of you said. I might go back and watch the recording too to make sure I didn't miss anything, but I really appreciate the feedback. That's super interesting about the reducing his cardiovascular risk. And I did have in mind that I might be able to use Harvoni if he doesn't get insurance. So although I had a really good experience with patient assistance program for Maverick one time, but anyway, and then I talked to him for a long time because, you know, he's right out of jail. And so I talked to him for a long time about his risks of OD if he relapses. So I'm definitely going to follow up on all that, Kaylee, because of that drug test. So thanks for the extra thoughts on that. I don't really have any other questions. I hope you guys could hear me better than I could hear you. I tried turning off my camera, but didn't work. Thanks.
No worries. Thank you so much, Jennifer. And we'll keep those.
Elizabeth,
posted.
I'm going to forward that article to you if you
Okay.
want to include it. Yeah.
Yeah, that'd be awesome.
It was from Dr. Feinberg. I can't take credit with finding it. So
No worries. We really appreciate that. I'll make sure you get that into the recap email. All right, we are ready for the didactic portion. I know that we have a question coming in from Dr. Leonard when he gets back, but do you want to share your screen or would you like me to advance your slides, Dr. Gilfus?
I'll share the screen. Thank you.
Right. Yep.
Stop that thing.
You have the capability now.
But I screwed that up. Yeah, is that showing up, Elizabeth?
It's perfect.
Yeah, okay. Don't worry, I'm not actually going to talk about all Lyme disease today. I don't have the voice or the appetite, and I'm sure y'all don't either, because it's I'm just going to talk about treatment, or actually diagnosis and treatment, and I'll do it in about 15 slides. And then time for questions or whatever we need. So, you know, this was kind of up to now. We talked about the history, the vector, some microbiology of the spirochete. We talked about the various clinical manifestations. We talked about prevention and then the controversies in Lyme. And today I'm going to finish up on this outline by talking about the diagnosis and treatment. So important factoid, you know, this is a disease process that you diagnosed with a combination of clinical symptoms and lab tests for the most part. So only exceptions to that's really e-migrans because it's too soon to necessarily expect the testing modality to be positive. Remember, the testing modalities, unfortunately, are nobody's favorite form of testing. So serology will hopefully go down in history as an unfortunate, you know, century or so of diagnostic testing where we're looking for the shadow of a microbe produced from the immune response. And, you know, serology is challenging to interpret. It's always indirect and requires a bit of thought. And anytime that is a prerequisite for interpretation, we're going to have errors. That's time delays and everything else involved. So just realize that in general, we use serology. I have never used culture. I don't even know how to order it. I don't know a lab that does it, nor is the yield high. You can do direct PCR on 2 tissues, only 2. So that's on a skin biopsy. If for any reason you were a budding dermatologist and liked doing punch biopsies and wanted to confirm that a skin lesion was e-migrans or something, you could do a PCR directly on the skin, or you can do it on synovial fluid. Those are the only 2 tissues that has any sort of utility. Everything else, it's too low sensitivity. Don't order it on blood. Don't order it on CSF. So really how we're going to diagnose this is serology. So, and then clinical manifestations. And again, why don't we like serology? Because we have to think about it. And sometimes that shadow is cast falsely from other microbes. So when do we get false negative serologies? Remember, just like we talk about for Hep C, HIV, Hep B, anything, there's a window period between exposure to a microbe and development of an antibody. And with Lyme disease, that tends to just be in the first stage. So if you're diagnosing somebody at the level of an e-migrans, just the rash, it might be too soon to detect serology, positivity. There's a possibility too that if you diagnose someone at the level of e-migrans and treated them promptly, that they may never seroconvert. And so I've seen patients who do never seroconvert, but it doesn't cast doubt necessarily on that diagnosis. It just means that we killed the bug before your body developed a complement of antibodies that was significant enough to trigger a positive test. So those are the false negatives. Really, otherwise, it's a decent test. As long as you give your body time to generate an immune response, trust it. Trust it with regard to its negative ability to rule out disease. False positives, more of a challenge. We obviously share our bodies with a lot of microbes. Some of those are spirochetes, and some of them have epitopes and proteins that can cross-react, and we can get false positive testing with some other spirochetes I have mentioned up there. This is a Hep C HIV echo. Those are disease processes that are renowned for causing chronic B cell stimulation over a long period of time, and other disease processes like Hep B and infectious endocarditis, even osteomyelitis. These are disease processes that the body they're frustrated immune responses, and sometimes you get non-specific production of antibodies, and some of those can cross-react with Lyme. So you can get false positive serologies for Lyme, just like you get false positive serologies for syphilis in these chronic inflammatory states, and so on and so forth. So, but in general, it's a pretty decent test, as long as we're testing the right patient population, which is somebody who might have a clinical manifestation explicable by Lyme. Yeah, that's actually what that, boy, I didn't even, I led myself to the next slide. And so that's what this says. Perform the tests on a patient where you're trying to answer a specific question. And so, is that arthritis Lyme related? Is that neuroradiculitis sciatica Lyme related? Is that Bell's palsy Lyme related? Is that influenza-like illness in the summertime Lyme related? Those are settings in which you can ask the question, and the serology might assist you in giving you an answer. Is that aseptic meningitis Lyme related? We all live in the endemic area now, so we no longer have to ask ourselves the first question. So now this is, I'm quoting guidelines here, and I don't agree with everything on here. So the guidelines say, do not perform serology in a patient with an E. migrans rash. I disagree for two reasons. Sometimes it is positive and confirmatory. And that's why I like to still check it. And also, then I'll also have often perform convalescent serologies later on, just to be confident and comfortable that a patient has been exposed to Lyme for reasons I'll explain. And so I disagree with the guidelines that say don't check serology in the setting of E. migrans. Yes, you don't have to. If you have somebody who doesn't have insurance, can't pay for labs, blah, blah, blah. Yeah, you don't have to. And for test questions, you certainly don't have to check serology in the setting of E. migrans. It's interesting. There's a disconnect here between clinicians and the public health people. The public health people want us to always check serology because they need to keep track. And so for record keeping and reporting, that's the other reason to get serology during E. migrans rash. So it is advocated that you do not screen asymptomatic people. I do agree with that one to some degree. I routinely break the third rule here that says don't check serology in people who have non-specific symptoms. Sometimes people are just not really good at describing symptoms. If I have someone with a wicked exposure history, tons of tick bites, but I get a sense that maybe their medical literacy isn't high, or maybe I'm having an off day with medical extraction of data. So I've broken that rule on occasion. I don't like to screen people who are just tired. But if you're having weird aches and pains and I don't know why, and you're a high-risk patient population, I might check you and stuff like that. But do know that you want a pretty whoppingly impressive test in that scenario. When you do testing, whatever your clinical question is, sort of will tune you into what part of the test result you look at. And what I mean by that is whether you look at the IgM or the IgG or both, okay? And Lyme disease is done in a screening and confirmation method, just like a lot of our antibody-based testing is done. So you're going to do some screening test that's wickedly sensitive, and then a more specific confirmatory test. And the classic that most of us remember is a screening ELISA or EIA. So you're going to do some sort of sandwiched enzyme link immunoassay. And then if it's negative, you're done, because it's a highly sensitive screen. Again, when could that be falsely negative? Like I said, if you check it super early on. usually the first week or two of symptoms with an migraines only. But if it's positive, you want to confirm that with a Western blot, IgM, and IgG. And the question, or what you have to think of as the provider and clinician, is what question was I asking? Am I asking about an acute manifestation, or am I asking about more of a later manifestation? So remember, the acute manifestations of Lyme are migraines or disseminated migraines, a influenza-like illness, perhaps aseptic meningitis, Bell's palsy, carditis. Yeah, that's about it. Late manifestations are going to be arthritic and neurologic outside of, say, the CNS and cranial nerve palsies. So more the neuropathies and neuroradiculaitises and stuff like that. So it matters, because if you're asking a question about a chronic manifestation like an arthritis, you really only want to look at the IgG. If you're asking about symptoms that are onset and have been present for only a month or two, then you can look at the IgM as well. Okay, so you don't want to be screening somebody for arthritis and look at the IgM. Too likely to be false positive. So it's important to really remember what the signs and symptoms, and that's why I like this little algorithm that the CDC has up here, because it says, which arm of the Western blot will it look at. Now, fast forward a little bit. This is what we've done since Lyme disease immemorial, since 80s, is do a Western blot, and I still like it. It's my preferred testing method. A lot of labs, due to cost and simplicity, have moved over to a simple yes/no for the confirmation test, so they no longer do a Western blot. So remember, Western blots are resulted in 13 bands, 3 IgMs and 10 IgGs. And so you get a semi-quantitative response. You get a semi-quantitative answer as to whether or not a person has a yay or nay on Lyme disease, but you get a number. With the new tiered method that most labs have moved to, you get a yes/no screening test and you get a yes/no confirmation test, which this algorithm is perhaps maybe a little more sensitive more quickly. I think that was terrible English with like triple negatives or triple positives in there, but the punchline is it's very sensitive. It turns positive more quickly. My own problem with it is I have not seen IgMs revert. So be really, really, really careful. Because I have seen misinterpretation by clinicians of persistently positive IgMs as meaning a new tick bite. And that's not true, especially with this new 2-tiered system. Just kind of think of it like once it's positive, it's probably going to stay positive. These tests are so sensitive, I don't see them revert very often. The other reason I don't love this method is because I can't ever do well, I'll tell you in a second why I don't love it. I hope in the next slide. Yay! It was the next slide. Good, man. I agree with whoever made this slide set. It's like they read my mind. The real reason I like the semi-quantitative Western blot is because we don't have an RPR that says with certainty that someone has had treatment success. And remember, the whole issue with Lyme is sometimes you don't have very abrupt response to treatment. And so it would be awesome if we had an RPR that would confirm, a declining titer that would say, yep, I've had treatment success. With the 2-tiered method that's just yes, no, you never have that. You're going to probably be positive forever. And those IgMs and IgGs can just hang on for literally decades. There's bona fide, studies that show IgM sticking around forever. So what I like to do is if I ever I like to document a Western blot on patients that I'm nervous about that might not do well. So if I see a patient who has sort of a complicated presentation and doesn't feel great after their round of doxy or something, I like to document a Western blot, send off an immunoblot, because it's a quantitative value, and the real utility of that is hopefully nothing. That's hopefully just a preserved data point in time. And if a person does well, I'll never recheck it. I don't care. But if anything comes up clinically in the future, I sometimes will recheck that, largely for one purpose, and it's to deflect attention from Lyme. So say somebody had a neuroradiculaititis or an arthritis, and I've documented that they have 7 out of 10 IgG bands positive, and I treat them with doxy. And then 2 years later, they come back and they don't feel good. They're hurt and they're tired, and maybe it's the Lyme, question mark. And it gets blamed on the Lyme from the orthopedist, and everyone else is blaming the Lyme. it's really nice to then be able to say, okay, let's test that theory. If you're still aching and hurting from that. And a lot of times what we will see is a gradual decline in those number of Western blot bands. By the way, I am woefully speaking outside of guidelines. I'm speaking purely from that awful thing known as clinical experience that's anecdote and wrought with bias. But I have found it to be very helpful to be able to purely to deflect people away from sort of their obsession that whatever symptoms they might get in the future are Lyme related. If I'm able to show them that, hey, you know what? There's no logic in thinking this is still Lyme. If it was still Lyme, you would have an escalating number of Western blot bands. In fact, what's happened after treatment, after a couple of years, you now have 3 out of 10 of your Western blot bands. And it literally allows us to, in a more scientific way, show the patient that, yeah, you're okay. This isn't Lyme. You're getting better. Hang in there. Patience is key. And so that's, and myself and the lab director highly disagree on this. He wants me to show him the point or the proof, and I can't. It's simply the logic and something I've been taught from a couple lectures as well and have done with clinical experience. So I'd advocate you do this, not in everybody because it's expensive, but in those where you think things might not go well or it's a complicated presentation or lack of rapid response, contemplate that. Boy, oh boy, I hope our future has an RPR equivalent for Lyme. We just don't have it quite yet. You can use some other modalities to try to prove or disprove that clinical manifestations are Lyme related. The most common scenario where I'll seek sort of exogenous data outside of clinical history and serology is neuro stuff. And I don't tend to do this myself because I'm kind of terrible at neurology. So I involve a neurology referral in these scenarios if I'm at all worried about a complicated CNS process or even peripheral nervous system process related to Lyme. And remember, Lyme guidelines are written by rheumatologists, neurologists, and ID docs. So there are 3 primary specialties that Lyme is central to, and that includes neurology. So you can get some special testing on CSF that would show maybe increased local production of antibodies production. And what you'd want to do there is get a Lyme antibody test in the CSF and the periphery and demonstrate there's increased intrathecal production. You know, in 15, 18, I don't know how many years now I've been treating Lyme. I've never ordered that test and never had it successfully ordered because it requires timing that's matched in the blood and the CSF. So good luck with that. And I don't think you need it. All you really need is positive serum testing and then a good neurologist to tell you that you could actually have Lyme as the etiology in the CNS and go from there. I don't know how useful this one is, but just know that Lyme is a reportable disease and we want to make sure that our labs are reporting. And if our labs aren't reporting, we should do it ourselves. Now, treatment. So what to say about treatment? You know, let's think back. So when I talk about treatment, I always remind patients a couple cool things, and that's that spirochetes are easy to kill. And remember, like big picture, we don't talk about multi-drug resistant syphilis, right? We don't talk about any spirochetes that become resistant to antibacterials. They just don't. They don't have the genetic wealth. It's very metabolically expensive for a microbe to become resistant to antibacterials. It costs it a lot. Sometimes it even costs its pathogenicity, interestingly enough. That's another talk. But these are fairly tiny microbes. They are intramammalian parasites for the most part. They have to live inside us. They don't have a lot of ability to do things on their own. And what they don't have is ability to become resistant to antibacterials. So all you have to do is choose one that's active against spirochetes that gets to the right target tissue. And it's that simple. So get the right drug that penetrates whatever tissue you're involved, and then give it for some amount of time that we don't really have great evidence of what the right duration is. So I tend to be an overtreater. I tend to, you know, if the treatment duration is maybe 10 to 14 days, I give 14. If it's 21 to 28 days, I give 28. Not because I have proof I need the extra 7 or 10 days, but just because rather leave any uncertainty out of the equation. So what are the actual agents that you use? Basically, any beta-lactam that's not a first-generation cephalosporin probably works. So Ancef does not, Caflex does not. You know, you don't want to use this first-generation cephalosporin, but But any other, third generation cephalosporin, second generation, or penicillin or penicillin derivative works. And then of course our tetracyclines work beautifully. Doxy works nicely. If someone's allergic to all that stuff, which I literally have never run into somebody who genuinely is allergic to cephalosporins, penicillins, and doxy. But if you did have that, a third line agent would be azithro, but outcomes are less impressive with azithro. So I have engaged our allergist and even had some desensitization testing, et cetera, when you have allergies to these medicines. So try to use the first line agents. Doxy is my favorite PO and I feel like has less relapses than some of the others, the amoxicillin, ceftriaxone, et cetera. So, and as I mentioned down below, there are still sometimes we go to IV, and that's really based on history more than evidence. So the more actually data we collect, there's probably very little role for IV medicines. And I'll talk about it in just a second. The doxy probably does just fine in all target tissues, and I mean that, probably all. But we hold off for certain situations where we still will give IV in central nervous system parenchymal diseases, just like we do for syphilis. Remember, syphilis is just like this. Doxy probably works, but we don't trust it for CNS syphilis. It's the same thing for Lyme. We don't trust doxy for CNS. And it's more just lack of data. Okay. And the only other place that you can really give IV therapy, according to guidelines, is if you have a patient who has arthritis that seems absolutely refractory to doxy and doesn't improve at all. Then remember, those patients probably have an autoimmune component, and the antibacterials may not matter at all. But before we label someone as antibiotic refractory Lyme arthritis, we want to give them the benefit of the doubt of a round of IV therapy. So, and that's sort of what this slide says. So really trust your doxy. I personally trust it better for most situations than the amox or the oral cephalosporins. Just the bioavailability is better, and I've had better luck. Long ago, we used to talk about having to treat carditis with IV therapy. You probably remember the natural history of carditis is self-resolution. And that's all. It takes a brave person to not want to treat that when someone's in heart block. And I certainly wouldn't advocate watching natural history there. But what you'd want to do is just put them on some Lyme active agent. Most of us still use ceftriaxone because that's what the data says to do until someone's PR interval is less than 300. And I have to look that up every time I see it because I can never remember PR intervals. But just know that as the heart block improves, feel confident to switch over to pills. And again, I mentioned that about the CNS parenchymal disease. You really want to, it's more history that says use IV ceftriaxone, but they'd probably do fine with doxy. And again, that arthritis concept, my approach, if someone comes in with arthritis, I give them doxy. And if they get better, but not perfectly better, and come back and they're still saying I'm getting swelling, genuine swelling, I'll repeat a round of doxy. So I'll do a second course. If they had response. If you have someone who comes back with no response to your first round of doxycycline and you're confident in your diagnosis, then you can go straight to IV for the second round. And if they don't respond to that, they really probably need to see a rheumatologist. So remember, there's this certain subset of people's arthritis that takes on a life of its own. There's certain HLA types associated with it, but it's what we call an antibiotic refractory arthritis. The other word for that would be an autoimmune arthritis. And as such, they need a rheumatologist. They need someone who's going to give them potent anti-rheumatic agents. But again, remember the good news there. That'll burn out. Once you've killed the bug, you've gotten rid of that antigenic stimulus. It just takes time. Now it can take years. It can be a real bummer to wait for it, but it will go away. And again, your rheumatologist can make their life better more quickly than time alone, and sometimes surgery as well. The arthritis is really also the setting that we treat the longest. You give 28 days, you justified in giving another 28 days if they're not better at the end, with a reasonable waiting period. I usually give them a couple weeks to a month to prove that they're not getting better before I do my second round. That last slide on treatment. You want to treat early, so obviously the whole impetus at diagnosing at migraines and treating promptly is because if you treat early disease, you prevent late disease, and that's great because the more robust your immune response, the more likely you to have slow to resolve clinical manifestations. So you'd like to treat early and remember that education component. The most important part of an interaction with any Lyme patient is that validation and education. So you got to make sure you tell them that, immunopathologic basis of this disease, and that yes, the bug is dead, but you may not feel better for quite some time, and that's normal, that's expected, and it's not a treatment failure. It just means that your immune system's calming down. The last thing on here I have never seen, that's a Jarrett-Herxheimer reaction. A lot of big word. It basically means it's like a tumor lysis syndrome for bugs. So sometimes if you have a massive burden of microbes that are super easy to kill, that are wickedly responsive to antibacterials, if you give them an antibacterial that they're sensitive to, it can rupture and kill them so quickly that could induce a little cytokine blast, a little cytokine storm. It's not unique to spirochetes, but it's seen with spirochetes, leptospirosis, syphilis, and Lyme. Apparently, I've just never seen it, but it is reported. So sometimes, if you are going to treat somebody who has likely early disseminated disease, so somebody who has an influenza-like illness, perhaps multiple E-migrans, in that phase where you think their body is chock full of spirochetes, not at the level of E-migrans, not at the level of a socked away in a joint, but one of these early disseminated phases, you can warn them and say like, hey, you might feel like crap for 24 hours when we start treating you, but it'll go away. And it's just simply the bug dying quickly and inducing an immune response. So there's the end. We finished with 15 minutes early. This was just a summary of all the things we talked about before. Talked about, of course, it being a zoonotic, antibiotic responsive, rarely fatal disease with an expanding range, very clinical manifestations. We now know how to diagnose and treat, and everyone needs to use DEET and bathe themselves in permethrin and buy guineas, and then remember the controversy really comes from probably poor communication between us and the fact that we don't have an hour to spend with every patient and the internet. It's all the internet's fault. But I'd open it up to questions. Anything you guys got? Anything that you've come up question-wise with serology or treatment?
Thank you so much, Dr. Gelfus. Really appreciate it. We do have some questions in the chat, and then Nicole, I did see you unmute, so we can just go ahead and if you want to ask a question, we're fine. And then Dr. Leonard, I did see some questions in chat from you.
Oh yeah, thanks. Thanks so much for doing that, John. That was really really great review. I really appreciate it. I guess I was curious what your experience has been, or what thoughts you've had on like repeat or recurrent infections, and what do you do as far as diagnostics with that and treatment based on if they've had known prior history of Lyme that was treated, but potential repeat exposure and infection.
What a beautiful question. And thank you, Nikki, for asking that, because I didn't touch on it at all. So the only blessing of being diagnosed with late Lyme disease, or any manifestation of late Lyme disease, is you probably are protected against future tick bites. Wrong word. Protected against future Lyme disease. So I had read an article recently that said basically if you present with Lyme arthritis, you're good. You're good. You can't get it again. So there's been no cases of somebody getting Lyme arthritis twice. And that's a concept that could expand to other late disease manifestations. So when I see somebody who has a really impressive IgG Western blot, I tell them, man, go out and tease those ticks. Give them your leg and see what happens. I'm just kidding. I don't really tell them that. But the concept is if your immune system is broadly expanded and broadly protective, you're good. The issue comes up in these patients that get seen at the E-migrans level and treated promptly. They probably don't develop a robust enough immunologic response. And we know from when the vaccine was out from 97 to 2003, that vaccine required boosters. And remember that vaccine, you only developed a single band on your Western blot. And so it was a very precise protection, but not impressive in broad range. So your question's awesome. The answer is it really depends when you caught your patient, when you diagnosed them, when you treated them, and how expanded their Western blot looked at the time. Nikki, the reason I do Western blots and the microlab director, Ryan and LaSalle hated me on this one. I still order Western blots on most of my Lyme patients because I want that semi-quantitative data. Whereas the new ELISAs are just yes, no. And the rebites, I also don't have any counseling to tell them. When I see them, I don't know how positive the Western blot is. And you can give semi-intelligent advice on future bite risk with that data. So that's my fudge factor answer, but awesome question.
No, thanks so much. I appreciate your insights and experience on that.
Thank you. And all right, Dr. Leonard, I saw a couple of chats from you. You can go ahead and expand on those.
So being a hunter, it's always a question. Everybody flips out, they're spraying their clothes with permethrin, blah, 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 blah. Never had Lyme disease as far as I know. Very few ticks in my lifetime. I'm 47 and I've had very few ticks. So is hunting high risk, or when you say high risk, are you only talking about an embedded tick?
For Lyme. So remember the different pathogens are transmitted from different parts of the tick.
Right.
Yeah, the Lyme certainly does. It requires regurgitation from the innards of, you basically got to get tick vomit in you, which is really appealing. But some of the other tick-borne illnesses come in promptly, like Ehrlichia and Babesia and stuff can come in a lot more quickly. So are you wondering how effective the permethrin and whatnot are?
No, I was wondering, when you talk about high risk, you're talking about high risk people, high risk environments. I mean, I think West Virginia is considered hyper endemic now. So it's just being a hunter that presents with vague symptoms. Are they high risk? Are you testing?
Yep.
Or because they can't give you an embedded tick, you want to see how it goes a little bit more? That's what I mean. Yeah.
Yeah, no, great question. I view somebody who has furry friends or engages in outdoor activities who live in West Virginia high risk. Isn't that terrible? I genuinely do. Like, you would be exquisitely high risk being a hunter. If you go out there, you're wickedly high risk. Yeah, you know what's really funny? When the CDC funded this expensive study a few years ago in Tennessee to try to figure out like who is at high risk of tick-borne illnesses, first of all, nothing panned out. Seeing a tick bite has no correlation with having tick-borne disease, by the way. It's funny actually seeing the tick bite, because these things are so small and so on and so forth. The only funny thing that came out of that study was being a bad golfer was a risk factor, meaning you spent more time off the green. It literally your risk of tick-borne disease correlated with how bad your score was.
So, you said that before. Yeah, that's really
isn't that
cool.
awesome? That's so cool.
Yeah.
But really, I would put anybody who lives in West Virginia who's an outdoorsy person. I just saw a lady who, she only goes outdoors to work on her flowers. We just live in a hyperendemic area, and I would say 9 out of 10 people I see never had a quote tick bite, have never had a tick bite that they're aware of. The Ixodes is just so tiny and such a challenge to find. So yeah, you're stuck with a lot of clinical suspicion here. A lot of clinical suspicion. And
Peter's kid had the reaction.
That's fascinating. Do you know at what point they got treated? Were they early disseminated or were they?
He was actually, he'd have to be early disseminated because it was a pretty soft call. But we talked about it and we went ahead and treated. I don't remember his testing, but he told me a day or two later, he's like, dude, my kid was sick. He's like, holy crap. And I was like, well, there you go. I'm like, makes us feel better. We had the diagnosis right. So
yeah. The other thing is other tick-borne illnesses can do it. Like Ehrlichia and Anaplasma absolutely can do a Herxheimer. And so, especially if you use something that would have killed that. So like Doxy, but cool.
Oh yeah, we use Doxy in our kids. Yeah, we don't care about their teeth. It's fine.
Be careful. Be careful with your hunting. Just keep bathing yourself in permethrin. Otherwise, you're going to present yourself with a knee arthritis in 3 years or something.
Probably, but I don't do anything. Nope. I'm pressing my luck, baby. Pressing my luck. I might hit that whammy one time, but oh well. Doxy works well. We'll be good.
Well said. Well said.
No update on my girl. No labs. I checked before I got on. So
I appreciate
don't know what's up with her thyroid. No idea. Have to assume she's fine, right? Because I think she would seek care.
Thank you. And you have another question? Do you have a pharmacy question?
I have a pharmacy question. Has nothing to do with anything we've talked about. So I don't want to ask until everybody's all done.
Perfect. Appreciate it. Does anybody else have any questions regarding Lyme disease for our cases today?
I have a super quick question to make sure I understood. So I saw a lady yesterday who was diagnosed with Lyme in August or something. She was treated. She feels better. She wanted retested. I said, you don't need retested. That was right?
Oh, Jen, what I was just lamenting some personal woes. Can you repeat that one more time?
Oh, that's so sad. Sorry. Yeah, just making sure that I understand you correctly today and that I said the right thing yesterday. I have a patient who was symptomatic with Lyme, treated in August, feels 100% better. And she came in yesterday and wanted me to retest her. And I said, I don't think that's indicated.
Yeah. So she had a positive test to start or a negative?
Correct, positive.
Yeah, no, if she had a positive, you're good. You're good. Yeah,
Yep.
there's no utility in rechecking. In fact, rechecking after you have a positive test with an asymptomatic patient is actually why I see about half the referrals I see, because people think they still have Lyme, and then we have the whole concept of what an antibody test is and blah blah blah. When I'm talking about preserving sort of a Western blot response and assaying again in the future, that's not a 1 month later. That's like three years later, 2 years later. If you recheck a Western blot a month later, it's going to look the same. And the PIA, no, you did perfect. You did great.
Thank you.
Yeah.
All right. Thank you so much, Jen. Anybody else? Give your good old echo pause. All right. I think you are safe to ask that question.
Okay. Is there a way, a system to submit a question or consult to the pharmacology team? I have ADHD kids having a reaction side effect to a medicine that doesn't fit with the pharmacokinetics. So I don't know if we really have that at WVU. So I can give, I mean, I've probably seen it probably over the last 4 or 5 years, but I can't, based on the information I have, give the parents a good reason why it occurs. And it doesn't make sense based on the pharmacokinetic data I can get. Do y'all know if we have something like that?
The School of Pharmacy has a drug information, like a team. So there are pharmacists on that team, and then the pharmacy students also work in the drug info center. I can't remember off the top of my head where that link is. And Samantha, if you're still on here, if you know, let me know. But it's through the School of Pharmacy website, I believe, and I can try to find it. They have a phone number, and then they have a website that you can submit the questions in, and then how you want your question returned. So then usually the pharmacy students work it up, and then one of the pharmacists in the drug info center will answer that question. So they might be able to look into that. You know, they're tasked with like looking at any literature, going over the PK, that sort of thing with whatever your question is. So that might be your best option.
Okay, perfect.
I'll try to see if I can find it, and then I'll send it to Elizabeth.
Thank you.
Excellent. Thank you so much. And thank you for your questions today. Stay safe in the ticks. All right, Dr. Leonard. Other than that, I just have one announcement. Next time we'll meet is November 9th. Dr. Feinberg will be discussing Hep C in childbearing women, and we'll try and do that echo transfer over. So appreciate that. And thank you very much.
Thanks, guys. Bye.